Welcome everyone to another episode of Talks with Toe. It's been a while, life's been busy, but we are back, and today I have a very special guest with me, Amy Hasson. How are you doing, Amy?
Doing pretty good.
So Amy and I have known each other for more than a year now, I guess, and Amy is currently a pediatric nurse.
Yes.
Is that correct?
I am.
And how did you end up, I guess I should ask, where are you working at right now?
Oh, okay. So I work at a hospital in the LA area. I will try to not go into specifics.
Yeah.
I don't know, trying to be HIPAA compliant and all that.
Mm-hmm.
But it's a large pediatric hospital.
Nice. And how did you, I guess, end up in the nursing field? What was that process like?
That's a good question. So I graduated from UC Irvine. I knew that I was interested in just learning about like people and how the body works. So I started as a biology major. And then I got to learn more about nursing and just volunteered and got to see how hands-on nurses are. Like they literally get to interact directly with the patients for their 12-hour shift or however long their shifts are. And around that time, like I also started just learning more about my faith and caring more about people. And I realized I wanted a job where I could actually make a difference and interact with people. So it was kind of like a field where I got to work with people and kind of like mixes together like faith and the things that I was already like interested in, like learning about the human body.
Cool. All right, we'll definitely come back to the faith aspect of it and what that means for you, obviously. But I guess for people who may be listening, what was the nursing program like when you were going through school? Like, what was the expectations? How difficult was it to get in?
So it's a little competitive, you might say. So you can either get directly admitted as a freshman, which means you're automatically in the nursing program for 4 years, or you can change your major like I did. So I changed my major my third year, and so the last 2 years are like your upper division nursing classes. So I actually stayed a fifth year to do those upper division years. So for those you have classes, and then you also start clinicals. So we either have 1 or 2 clinicals at a time, which is like a 12-hour hospital shift a week, so on top of classes. So there would be times where we would have 2 clinical shifts a week and classes, or there would be times where we'd be in 1 clinical.
You guys were rotating, right?
Yes, so we started with mental health and kind of like med-surg. We went through like OB, labor and delivery, and pediatrics, and then we did critical care.
Out of all of them, which one was your favorite?
Well, I would have to say pediatrics. Which is kind of sad because it was our shortest one. But that's okay. I guess I get a lot of pediatric experience now. So
yeah, as a pediatric.
It ended up being okay.
Nice. So what was kind of that experience like? Were you doing it with classmates or?
Yes. So each clinical group, well, pediatrics was a smaller group, maybe like 5 people. For me, 5 to 10 people in your clinical group. You would go to the hospital the same day. So you had a day assigned that you would go. And then you would be paired with a nurse that day. And then the goal was like to get to do as many procedures as you could, just learn as much as you could about nursing. We really didn't know what we were doing, especially like the first couple clinicals. But yeah, so the goal is to get like hands-on experience. And then you also have a lecture that goes with it. So for pediatrics, we would also have a pediatric lecture where we would just learn like everything related to the pediatric population. So pathophysiology, like what drugs they used, clinical manifestations, treatments, all of that. So like the goal is the clinical part would kind of like
line up somehow.
Yes, line up. Then there was times we'd be in clinical and see something and like we hadn't learned about it in lecture yet. So then it's like you just kind of have to go and
so what were some of the hands-on things that you guys were actually doing as nursing students?
Anything a nurse could do, we were allowed to do under supervision.
Okay.
Is what we tell people, and that means we were giving very basic things like giving like injections, so that's like intramuscular, kind of like flu shots, but any medication that way. We could insert nasogastric tubes, although I never had an opportunity. We did a lot of Foley catheters, which if you don't know what that is, look it up.
Maybe we could talk a little bit about what that is. So I guess maybe what is a nasogastric tube for people who don't know what that is?
Yes, that's a good question. So it is a tube that goes from your nose into your stomach, usually a little bit like past it, or there's also jejunal ones which go past it into your intestines, but same concept. The purpose is decompression, but you can also get feedings through them. So sometimes people will need it after like some kind of surgery to remove like the gastric contents, or if they need to get temporary feedings, they can get it through their nasogastric tube.
Nice. And I guess what was the other one? The other one was the
Foley catheters.
Foley catheters, yeah.
So that one is if for some reason someone's not able to urinate. Basically, it's like a catheter or a tube that you put through the urethra, and you can relieve them of their urine that way.
Fun.
So that's a fun one. It's really fun on kids. No, I'm just kidding. It's not that fun to do, but like as a nurse, you have to know that if it's ordered, it's necessary.
Yeah.
So, yeah. But I got a lot of experience because they actually get them a lot in labor and delivery. So in clinicals, I got a lot of experience with that, just because if you have an epidural, you have to get a Foley catheter.
And what's an epidural? I guess.
Okay, that is a good question. So it's basically like numbing medication, I would describe it, that goes into your spinal, like the space around your spinal cord. So it's what you get when you are delivering a baby to help relieve some of the pain.
Nice.
Yes.
So I guess you're in that clinical setting a lot. What was one of your, I guess, like experiences that was not what you expected to happen?
Not what I expected to happen? That's a good question. I feel like you can't really expect things a lot in nursing because like things just happen. I mean, there's like, you never really account for like patient behavior, right? I mean, at least I didn't, like in the beginning. People just do ridiculous things sometimes. Like we had a patient that got really upset and he just like threw his food like all over the walls and like we just walk in and it's like, why? But like, you know, those are like the things you don't plan for.
You guys have to clean it up and stuff.
Yes, and luckily like we had help from our lovely hospital staff, but yeah, I don't know, like behavioral things are like usually unexpected, and sometimes make good stories, so you kind of just gotta take them with a grain of salt and like just laugh and be like, well, this is nursing, you know. In the emergency department, I did compressions for the first time, like during a code, so I think I wasn't expecting to do that day. But it was a teaching hospital, so when they had the code blue, like they just brought me in to do compressions, which was actually a really good experience, because it's very different from a mannequin, as you can probably imagine. Yeah, but I learned a lot from that.
Yeah.
Sometimes you just have to go and think about it later.
Yep. So, chest compressions?
Yes.
Chest compressions, right?
Chest compressions, quoting Dr. Mike.
Yeah. But also, any CPR
yes.
class that you'll ever take.
It's all about the chest compressions.
Yeah.
That's the most important thing, if you think about it.
Yeah. I guess, why is the chest compressions so important? Like, so, say someone goes into cardiac arrest. They're having a heart attack or something. Why is the chest compression so important?
Well, so you're thinking, okay, like, their heart isn't circulating blood and they're also not breathing. So, like, obviously giving rescue breaths and oxygen is important, but if the blood isn't circulating, then there's no point in oxygenating their blood because it's not being circulated to the tissues to actually, like, help keep those tissues alive. So the most important thing is to actually keep your blood circulating your body. Or else it's, going to start dying off. Your tissues are going to start dying. So you need that constant blood supply.
Yeah. Nice. So I guess
it's more important.
Yeah, when you graduated, what was that experience like, and what was the job search like afterwards?
Well, so when you graduate, you have to take a board exam called the NCLEX. So I spent many days studying for that, while also applying for jobs. So it's kind of hard to like solely focus on applying for jobs because you're also focused on passing this test that like it will determine if you get your license or not. Because if you don't pass a test and have your license, even if you were accepted for a job, like you can't really practice without a license, so you can't really take the job. So there was like a bit of pressure from that, but I think school, like for the most part, if you're in a pretty decent nursing program, prepares you pretty well for the test. And then it's just like if you actually study and try, like you should be okay. Yeah, so I was doing that while applying for jobs, and yeah, just
got the job.
Got a job. Crazy story. I didn't know I was going to get this job because I interviewed for it in June, and I didn't find out that I got the job until August. So I like literally thought that I didn't get it. Like, okay, they never got back to me. I thought they were ghosting me, but I found out it's more because their union was like in negotiations, so they couldn't like, yeah,
interesting. Okay.
They couldn't really give official offers until.
So are most nurses like in unions, or?
A lot of hospitals have unions, and from my experience, I think it's a good thing. I mean, it's never perfect, but the goal is to like kind of have a body that's like fighting for the rights of nurses. So I think it's because of unions that nurses have things like patient ratio laws, where in certain states you can't have more than a certain number of patients assigned to you depending on the unit you work on, which is really safer for the patients and safer for the nurse, because you can imagine, like, if you're taking care of too many patients, you're going to miss things, and that's really going to be harmful for the patients in the end, and that's really stressful for the nurse to feel like he or she does not have time to adequately take care of their patients, because most nurses, I would say, become nurses because they want to take care of people well. So
yeah,
it's frustrating if you feel like you can't do that, I would imagine. Luckily, I'm in California, and we have mandated patient ratio laws. So
what is the ratio for you guys at your unit?
So for me, I can have up to 4 patients. So pediatrics is a little different because in general adults, you can have up to 5, but I think people tend to just be more cautious with kids. So my maximum is 4, which I'm grateful for because they can have a lot going on with them sometimes. And if something's happening with all 4 of them at one time, it's like hard to manage. So I can't imagine having a 5th one thrown on there. Also, I'm new, so I feel like I'm just always struggling to be like caught up with like my time management. Yeah. And then like in ICUs, the maximum is 2 patients.
Which I guess makes sense.
There's a lot going on with them.
Yeah. Nice. So I guess going back to that motivation, how does your faith tie into, I guess, your work, why you chose to take care of people in nursing?
Yeah, I think like my faith is probably the main reason why I care about people, because like I genuinely believe that like God created all people and loves them, and wants to know them and just has a heart for them. So because of that has caused me to care for people and just want to be a part of a hard part in their lives. And I know it's a small thing to be there for like a 12-hour shift. Even like the course of their hospital stay is usually a lot longer than that, but like I get to be there for those 12 hours, especially in pediatrics, like with a whole family. And yeah, I think that's like really cool.
Yeah. How is I don't know, how's it been interacting with patients and patients' family too?
I think like a lot of people say they don't want to, like if they don't want to do pediatrics, it's because they like are worried that the families are going to be overbearing and like just super critical and just like always hyper vigilant and be like, what are you doing with my child? Which also would make sense because it's their kid. And like, we just get so used to our day-to-day in nursing that like we forget that this might, like, something so simple to us might be confusing to the parents or might seem scary, like even taking vitals, like, you know, like that's so routine for us. And so sometimes we don't even explain what we're doing, but they might not know what we're doing. So anyways, with that tangent, I think people normally would, their reason be they're worried about working with families. But for the most part, my experience has been that parents have been really great and hands-on, and like they want to learn how to take care of their kids, because sometimes like their kids are going home with medical problems still that are going to need monitoring and they're going to need medications. So we have to teach the parents like how to take care of their kids, and usually they're pretty hands-on and like want to learn. And also they're like a great resource for you because they know how their kid works. Like if their kid only takes their medications mixed in applesauce, they're going to tell you. And that's going to save you a lot of time trying to figure out how to get this kid to take their medicine.
I'm assuming you've had to do that.
Yes. There have been times.
What are some of the most, I guess, interesting ways you've had to get kids to take medication?
I'm really not proud of this one because it's not the healthiest, but we really couldn't get him to take his medicine any other way. We tried mixing in orange juice. We tried mixing in an apple juice. We tried ice cream. Like, and ice cream is not healthy. He didn't want ice cream, but he wanted soda. So in a desperate moment, I let the mom mix his medicine in soda and give it to him. And he finally took it.
Wow. So,
you know, you have to outweigh the pros and cons. Like, he needs this medicine. Soda's not healthy for him, but maybe a little bit of soda right now. I don't know. It was probably not a good nursing judgment call, but yeah.
Well, if it's serious
sometimes you gotta do what you gotta do.
Yeah, kids are always hard, you know, because they have very specific like wants.
Yeah.
And then
sometimes we just have to hold them down and force them to take it, which is always hard, but they need it. So.
Yeah, and they already don't feel well anyways. So.
Yeah.
Nice. So I guess pediatrics includes all the way up to 21, you said?
Yeah. We can go up to 21. That's mainly because we see some patients with chronic conditions. And so that way it just helps with like continuation of care. They can stay longer, insurance-wise, all of that. I don't really know all that goes into the insurance stuff, but usually it's more helpful for the patient.
So how do I guess, what have you learned about how hospitals operate, and like, what are some of the things that you're just like, oh, I wish this was better?
Oh, that's a good question. I'm surprised at how many resources we have. I think it's especially because we're working with kids. So that's something like I was pleasantly surprised about. I think we have, for instance, like the nurse assigned to the patient, and then if they need like therapy, they'll see a respiratory therapist and maybe also an occupational therapist. And we have child life, which makes sure like kids can have time to go to the playroom if they're stable enough for that. If not, they'll bring game consoles to the room for the kids to play. We have dietitians that like if the kid is for some reason struggling to gain weight, or there's any kind of dietary needs, for instance, our cystic fibrosis patients have to eat a whole ton of calories. So dietitians work with that. But there's, so all of that. But there's so much that goes on with like getting kids home safely that I like wasn't aware of. Like, for instance, they might need some medical supplies at home. Like if they're going home with a G-tube, which is a like gastric tube. Basically, it's a tube into their stomach that they can get food through if for some reason they're not able to eat by mouth, or they're not able to eat a sufficient amount by mouth that is able to keep them at a healthy weight. Sometimes they'll have the G-tube and they get feedings through that, but it's like run through a pump. Like it's a formula that goes through a bag and the line is connected to the G-tube. Liquid formula. goes through the pump. So sometimes they have to go home with that. You have to make sure it's ordered before they can be discharged. And yeah, it's kind of sometimes hard to organize all of that. Maybe because I'm new, so I don't anticipate all of their needs yet.
Yeah,
so I think a lot of like the things that like I would like to be changed are just because I'm inexperienced and I'm still learning. But yeah, so they need education on how to use whatever supplies they're going home with. Yeah.
Dang, that's a lot.
Yeah.
What is your day-to-day, like, in a single shift, like, because I don't think most people know what, like, nurses' days actually look like.
What nurses do.
So, like, what is your, let's start, like, from the beginning of the day, like, what is that like when you wake up?
When I wake up, from when I wake up until I come home.
Yeah.
I'll quickly walk you through my day. So, usually right now, I'm switching to nights, so everything I'm saying, just convert it to PM. Probably because I will be sleeping during the day and waking up at nights.
Mm-hmm.
But when I was on days, I would wake up at 5 a.m. Because I would want to get to work early. So nurses start at 7. So I would usually leave around 6 a.m. to get there by 6:30. So I could have time to just chill out in the break room. Kind of like, my last sips of coffee. And then get to the station a little early to see who my patients are going to be, start looking them up. And then at 7 a.m., nurses do handoff report. So the nurse that was there the shift before will go through a summary of why that patient's here, how they did on the previous shift, how they've been doing during their hospital stay, anything you need to look out for, if any labs are pending, if there's any procedures scheduled that you need to know about to get the kid ready for. That's kind of what handoff report is. Mm-hmm. So you do that for all 4 of your patients. You ideally will have time to go see all of your patients.
How long does that take, usually?
The whole process can take like 30 minutes, I would say.
Okay.
So, yeah, you get the information on your patients, and then ideally you'll be able to see your patients. If there's any fluids running, you'll double check the fluids, make sure they're set to the right rate, all of that. Because you want to make sure like things are like correct at the beginning of your shift, because you don't want to be like 4 hours in and realize like their IV is set at a too high rate, like they're getting too many fluids. So the idea is you see the patient right in the morning. If anything's off, you can notice it right away. So by 7:30, you've ideally had report and at least put eyes on your patients. Usually like we'll just peek in the room, because at that time most of the kids are still sleeping, so we really don't want to disturb them. But sometimes we have to wake them up, because then for our unit, we have to get their vital signs every 4 hours. So usually around that time, we'll start getting their vitals. And then we do like this huddle around 8 a.m. That's interdisciplinary. So it'll be like the physical therapist. Sometimes the social worker will be there. Usually the social worker is there. And just other team members. And we'll quickly go through what the needs will be for the patient that day, just so something doesn't get missed. Trying to give an example. Like maybe there's a kid going home, but the physical therapist has to clear them to be able to ambulate or something like safely before they can actually go home. So the physical therapist is at those like briefing meetings, and we'll be able to like say, oh, I need to go see that patient today because they're going home. So things like that, so that they don't get missed.
So there's a lot of like, I guess,
there's a lot of planning. There's a lot of logistics. Yes,
a lot of planning.
Yeah, and the whole team is involved. Like the doctors need to know all of that too.
So just how big is like the whole team considered?
It kind of depends on how many patients we have, because there's one nurse for 4 patients. I want to say there's roughly, our unit's pretty large, so anywhere from like 10-ish nurses to maybe,
oh wow, that's a lot of patients.
I don't know, 10 to 15-ish nurses maybe when the unit is fully staffed. There's usually a couple physical therapists. Oh, respiratory therapists, usually a couple. We have PCAs, which are like techs that help the nurses with like bathing and things like that, and giving food to our patients, which is super helpful. And then I think we have one social worker.
Okay.
Yeah.
Is it the same social worker every day? Or is it?
Yeah, so that's the thing. Social workers are only there like weekdays and day hours. But then I believe there might be one on the weekends, and then there's like on-call ones. So like the hard thing about working nights is people might not actually be there in person. But at least there's usually always someone on call that if you need something, you can call them. Anyways, I feel like I want to go through this part more quickly because this might be boring for some people. But
sure.
So, okay, we do all that, whatever. Then we go see our patients. We get all their vitals. Usually they have morning meds, so we give their morning medications. If there's anything we need to do in the morning, we'll do it then. Like if they have in order to, for instance, put in a nasogastric tube, we'll get the nasogastric tube in. If they need an IV, like if there's a new patient coming in, sometimes there'll be an order for that. So it really depends on the day because you might start with all four, you might get someone coming in right then. So then, anyway, you do all of that. And then it's a lot of communication with the doctors. They'll start doing their rounds in the morning. Usually the nurse tries to be in there when the doctors are seeing the patient, just so if there's an update to the plan for that day, everyone's all aware. And the nurse can then double check with the patient after the team leaves and make sure they understood everything the doctor said and make sure they're on the same page with the plan. But they can come at any time, like in the very early morning to later morning, because they're trying to see all of their patients too. So there's no set time like they're going to be here then, because they don't want to limit how long it's going to be with the other patients. So it's like you never really know when they're going to be there, but like when they're there, you really want to catch them because you want to get an update on the plan. So like as you're going through the day, you're like keeping your eye out for like that patient's team of doctors so that you can get updates from them. Usually at this point you try to start charting some things. You will also definitely assess your patients, especially in the morning. It's good to get a thorough assessment because if something changes throughout the shift, you want to know that. And if you didn't really look at them in the beginning of the shift and you all of a sudden notice something later, you're like, wait, was that like that when I first walked in? Is that normal for them? You want to know that. So like it's good to get a full head to toe assessment of the patient in the morning. Usually when you're doing your morning vitals. Then, yes, you will communicate as you're doing this. If there's any concerns, you're sending a message to the doctor, and then like they may add some orders based on
Paging
that.
the doctor?
Yeah. So we do it like on a computer.
Oh,
so like we don't actually like use pagers, but I think they still do.
I think most doctors still use pagers, right?
So they get the message, I think usually to their phones. But then depending on what it is, like they may add some more orders, which may or may not include some more procedures that you need to do with your patient. So that's hard to kind of give like a day-to-day because it really changes every day. Then by 12 o'clock, you're like doing your other set of vitals, assessing the patient again. If they have an IV that's going, you're looking at it every hour to make sure that it's not, there's no problems with it, that it's still going. Oh yeah, that's true. You want to make sure that the bags are full.
There's still stuff in it.
But you want to make sure their IV site is actually patent, which means it's working. That's just, we call it checking for patency, but just making sure the vein's still good.
Yeah, it's a big
the fluids
issue.
are flowing in. There's no redness. We will palpate it to feel if it feels soft still, which is good. If it starts to feel hard, that's a problem because that means the fluids might not actually be going into the vein. They might be going into the spacer on the vein, which means they'll need a new IV. So sometimes we have to take the IV out and start a new IV randomly. Yes. So we're doing all that. At some point we'll go to lunch.
Really?
Yeah.
It sounds like you guys are doing a lot.
Yes. I tend to go later because, like I said, I'm new, so like I tend to just go and then I'm like way behind on my charting, and then like they're like, do you want to go to lunch? But then I'm like, I feel like I haven't charted anything. And they say if you didn't chart it, it didn't happen. So you just kind of have to cover yourself and write down everything you do.
You guys are charting? Are you like writing it down, or are you doing it on a computer now?
We're doing it on a computer, thankfully. Okay. Yes.
Yeah, because that's a huge thing, is the electronic medical record push.
Yes.
So I don't know how many hospitals are actually like fully implemented that yet. But
every hospital I've been in does electronic medical records. I think it is definitely the norm in California, at least. I would say probably in the U.S. it's the norm. Maybe some smaller hospitals do paper charting, but it definitely saves a lot of time. Yeah, so like you would do an assessment of your patient. There's like a flow sheet where you can chart the assessment, so it breaks it down by body system, and then like there's pre-populated kind of like options of what your patient may or may not look like, and then if none of those apply, you can add your own comment. Okay. So if the comments that are there apply, it saves a lot of time because you're not actually having to type everything out.
Okay, yeah, that makes sense.
And then you're putting in all of their vital signs. You're putting in every time they eat or drink something, or go to the bathroom, or pee. Like we keep track of, like, we call it eyes and O's, or intake and output. We keep track of how much you drink, how much fluids you're peeing out, because we want to make sure that it's an adequate amount.
Dang.
So you don't know that, but something you might not know if you're a patient, but your nurse is paying attention to how much you're peeing. So we're trying to keep track of all of that while we're doing our vitals and all the other procedures. And then eventually we'll go to lunch sometime in the afternoon-ish, so it's like a 30-minute break. And then we will come back. Usually by then it's time for another set of vitals. And if you have to send a kid home, you're calling the pharmacy that the medications were sent to, usually, just to make sure they got them. If you have a patient that is working with respiratory therapist, you'll be in contact with them just to see how is the patient tolerating their respiratory therapy. So that will be more for like kids that have, like, for instance, asthma or something like that. You always want to know how your patient's doing. So it's always good to touch base with the people that are seeing the patient and asking how they're doing, because you don't want anything to be a surprise if they're not doing well.
Dang. So what time do you guys usually finish your shift?
So usually, well, technically we end at 7:30. Sometimes it can be later, depending on how things go. Sometimes you get a few surprises at the end of your shift and you can't anticipate it, but then you still have to do like the handoff report after. But officially we're supposed to be out of there by 7:30. Yeah. So that's, I mean, there's no typical day, but that's kind of, then I drive home, and usually I shower right away because I just feel like gross from the day. And then I eat after I shower, usually. And then it's like almost time for bed.
Nice. But you usually have 3 shifts a week, right? That's normal?
Mm-hmm.
Okay.
Yes.
Yeah, that's crazy.
Yes, I'm not doing these like 12.5-hour shifts 5 times a week. Don't worry, that would be crazy.
Probably would not be too healthy for you either.
Hey everyone, hope that you're now aware that we have our podcast up on Spotify, Google Play, and also Apple Podcasts. Additionally, we started a YouTube channel and we'll be slowly improving our video content there, so be sure to head over there to like and subscribe. Now, back to the show.
So, I guess, what is your long-term goal for healthcare? I don't know, maybe missions?
That's a good question. Yeah. So we've gone on a medical mission trip together to Vietnam.
Yep, with Dr. Iggy, or Dr. Trin.
Shout out, hi Iggy. But we are going again in March. So I just love like missions. I think that's another thing about like faith. Like I didn't have the desire to go to other countries and help people before like I became a believer, like follower of Jesus, but because I know that God's heart is for the world and he loves the world, I think he's given me that. So definitely not something that was like natural to me. but something that I desire now. And I just love learning about different cultures and getting to just experience them and just learn what life is like for people, do life with people.
Yeah.
Talk
so
about God together.
Where have you been, I guess?
Oh, that's a good question. So I have been to Vietnam. I also did like sort of like medical missions in Indonesia, in Bali. That was like less structured, but still really cool. It was a lot of like community health, so a lot of education on.
Were you more in like the rural areas or like the city?
Yeah, we were definitely like in like kind of like the poor villages. Like people were living in like what are those called? Like those kind of like shipping containers.
Oh, wow.
Like it was like a whole family would live in one shipping container. Like no running water in this village. Except for the school that the organization we were built had like sinks with running water, so the kids would use that. So that was just a lot of like education on health topics. I remember we did,
which is super important.
Yeah, it definitely is. Like health education, prevention is like so important. Like if you can prevent someone from getting a disease in the first place, that is just great, because that like takes away the need for all these other interventions. And
right, yeah.
It's just like the best model for healthcare. So it was great to be a part of that. But we literally had a day with like the women in the village where we talked about like STDs and like just the very taboo topics in that culture. We like closed all the doors. We like had babysitters for the kids in the other room, and like they just had so many questions, and because they never get to talk about it, and it was like one of like the best days we had interacting with them, because it was a huge problem in that village.
Dang, that's crazy.
Yeah. So got to do that. We did some clinics in some male drug prisons, which was pretty fun actually. Prisons in Indonesia are very different from American prisons. Yes, so all of that. And then I've been to the Middle East with Crew, which is an organization that we are both involved with in our undergrad and we volunteer with now, but it's a partnership that our campus had in the Middle East area.
Yep. Security reasons will not be named. But
will not be named, but it's a beautiful country, and there I got to work with college students and just talk to them about faith and who Jesus is and what that looks like. And that was an amazing opportunity, and I love that country.
Yeah. Who knows? Maybe one day you'll go back.
I would go back. It would not be hard for me to want to go back. Yeah.
Nice. I guess, what are you looking forward to in this year's trip to Vietnam?
Ooh.
Or maybe, what are some of the highlights also of your trip from last time? Cause,
that's a good question.
I mean, I was there, obviously, but...
You might be able to guess. I really love the orphanages. I just love kids. So I think that was like a highlight, because we just got to spend some time with kids that don't get enough love and attention, and just spend some time loving them. Like, just honestly holding kids means so much to them when they don't get that like physical affection, and it's actually really important for like their social development. So I think that was really special, and also kind of heartbreaking because like that's not enough.
Yeah. Yeah, that was definitely, I mean, there's a lot of things on that trip that were very hard. But like, yeah, at the same time it was super cool to just see like how little like you actually needed to do to kind of bring some of that joy back into people's lives.
For most of it, you just need to show up and be there. Just knowing that there's like people that would come from across the world to just spend a day with them, I think means a lot. because it's not a normal thing that people want to do. And I don't think I would want to do it if God didn't give me that desire. Because it's a lot.
Yeah.
But yeah, so I think that was definitely a highlight. And I'm really excited to see like what else we can do this year.
Yeah, it'll be fun. I think we'll be going mostly the same areas, except we'll be going up into the highlands in northern Vietnam this time as well.
Yes. So where did we go last time?
Well, let's see. We started.
Where did we not go?
We started in Saigon. Yeah, we started in Saigon, right? We kind of went. Well, I went to Hanoi, but not everyone went to Hanoi. So we mostly stayed in the Saigon area, and then Da Nang and Tam Kỳ.
And we went to the Highlands.
Yeah, the Highlands, like west of Tam Kỳ, which is like probably about. It was quite a long drive. Still,
it was far.
It's like 4 hours maybe in the mountains. Da Nang is by the ocean. Tam Kỳ is more like in the middle, and then the Highlands are obviously on the west side. But yeah, we did crazy things. We visited a leprosy clinic.
Yeah.
That
was a highlight too. I feel like they're all highlights, which is hard.
Yeah, I think we're doing stuff with the Hmong people.
Yes, I'm
this
excited
year.
about that. Actually.
So that should be fun.
In nursing school, we read a book about like a Hmong patient in California and just like how the cultural barriers impacted her health care. So I'm really excited to get to work with these people because read a lot. I kind of want to reread the book in preparation.
Yeah.
The book is called The Spirit Catches You When You Fall Down, and it's a really good book if you're looking for one.
Interesting. Nice. Yeah, that's the thing is like there are a lot of cultural things that can affect people's healthcare, because even in China, because I've probably been in China way too many times at this point, but in China there's still a huge emphasis on traditional Chinese medicine, even though the country is pretty modern now. Like there is basically you can go to medical school or you can go to traditional medical school, and they're seen as equivalent and the same thing. Well, not the same thing, but they're seen as like
equivalent,
like exactly the same. And
like you can do one or the other.
Yeah, you can do one or the other, and they're both considered doctorates and doctors. Traditional Chinese medicine is very interesting because a lot of it is still very much rooted in like qi medicine and like herbal medicines, some of which like now Western medicine is kind of looking at more.
They're starting to be like a whole field of research looking into,
especially in UC Irvine, because there's a lot of Chinese professors here and Chinese immigrants in Irvine in general. So like there's a lot of push now in this area to at least verify at least some of the medicine in traditional Chinese medicine and see how much of it is actually like still
could actually be useful.
Yeah, like still, because there are things that have been found that are still like very useful. Like a lot of the herbal things are like pretty useful in some cases. We just don't necessarily know why. But like statistically, the studies have shown that they help. So
well, people keep using it, so clearly it hasn't been harmful, or people wouldn't keep using it.
Maybe, but I don't know.
I feel like a lot of it is passed on through tradition, and it's like you do it that way because that's the way it's been done. But like they definitely are trying to integrate that more. I know at the UCI Medical Center, they offer acupuncture as a treatment. So they literally had like someone come around that did like acupuncture on our patient, but that's like in the hospital setting.
Yeah.
Which was pretty cool that they could get that right there.
I had a lecture once from this researcher. His research was basically like trying to like detect qi, but like qi, like his argument is basically like qi is basically just like the way that Chinese people like describe energy, right? So like he's like, well, like how can we like using like the Western technologies like detect various forms of energy? He's like, like body emits like heat or like electricity or like light.
Mm-hmm.
And those are like the three main forms of energy that you can get. So his entire thing is like, basically, he would have people do these Tai Chi exercises,
Mm-hmm.
and then he would like take all these measurements after they did these Tai Chi exercises, and then take the measurement. Well, he would take the measurements before they did it, and
Before and after.
And like,
that's really interesting.
it was kind of interesting. I was like, oh, okay.
Do you know if he found anything?
I mean, the
Like
obvious
what his
ones.
findings were.
Like the obvious ones is like, you do any type of physical exercise, like your body temperature will greatly increase, and like there was like a snippet. He did find like that certain Tai Chi exercises like increase people's body temperature more significantly than other forms of exercise. The one that is kind of the weirdest is that he was trying to detect like how much light gets emitted from someone's arm after they do Tai Chi exercises. So he created like this box that was like supposed to be like a light proof box, right? But there's a light detector in it. So after you do these exercises, you would stick your arm in it, and then it would detect any light that was emitted by your body. Because your body actually emits like photons. Not a lot, but like it does emit photons because like you have chemical processes going on.
So does that mean we're technically emitting light?
Yeah, we're emitting light, just not a lot. Yeah.
I'm gonna tell people that.
Yeah, but it is a thing, you know. So yeah, so it's like on the scale of like countable photons, which means like you can see, like if you were to actually catch all the photons, like if you were able to do it, it'd be like you'd be able to count it. Whereas like the light that
Which means it's a small amount.
It's a very small amount, like a very small amount. Like the amount of photons hitting us right now from the lights around us is like uncountable. It's like trillions of photons probably.
I can feel it. I'm just kidding.
Yeah. So.
I can feel all the photons.
Yeah, I don't know. It's interesting, you know. I think there is a lot of things that, that may be useful in cultural medicines.
Yeah.
And a lot of things that may definitely not be useful.
I mean, I definitely learned more, you know, obviously the Western medicine. Yeah. So I think that's just what I'm used to. But I think if something is found to not be harmful and a patient prefers it, and there's a way to incorporate those practices with Western medicine, then it's worth it because that will make the patient comfortable. And
yeah, patient comfort is huge too.
Yeah.
Because there's been a lot of studies also that show that patient outcomes are typically better. You know, the more, I guess the better mental state they're in also. Yeah, because there is still that like mind-body duality that we don't really know much about, but you know enough that like the way you like feel and the way you are emotionally and like mentally does actually affect the way you get treated, and also like whether or not you recover faster or slower. So I don't know, that's interesting. Well, do you have I guess any other things you're excited about in your job, nursing wise?
I don't know. I just love kids and working with kids, so I get excited about seeing who my patients are going to be each day. Yeah, that's fun.
How are the other nurses doing? Like, you guys work together closely, obviously as a team. I guess how often do you like cross paths with the other nurses?
Oh, quite often, especially because I'm new. I have questions literally all the time. I mean, like simple questions of like, where do I find the cotton balls? To like, how do I program like this IV fluid? Like, what rate should it be going at? You know, that's like a more serious question because you want to make sure like you're giving an antibiotic at the right rate. So pretty much like right now, I feel like anytime I do anything, I'm asking someone just to double check. But in general, even the experienced nurses help each other out a lot. Like, say you have to run into a patient's room because they need something right then. but like you also have to administer a medication to another patient at the same time. Like if there's another nurse that's free, usually they're like more than willing to help you out. There's a lot of things that require 2 nurses, so we're always helping each other out for that. Like if they have any kind of central line, which is usually like an IV, like a catheter that goes, it's more central than an IV, like it goes actually into like
the heart,
yeah. Like which is kind of scary because think about it, it's a tube that goes into your heart, so that's why they want to actually make sure to prevent infection. Not that you are definitely trying to prevent infection with regular IVs too, but these ones are more serious because if there's an infection, it's going directly to your heart, and that's really bad. So when you're changing the dressings for that, you have to do sterile technique, and to be able to do that, usually you need 2 people, so you're usually bringing another nurse in with you. Actually, you should definitely be bringing another nurse in with you. If we're doing things like suctioning a patient's nose, if it's like a baby that's squirming a lot, usually we'll bring in a nurse because unfortunately they're going to be the ones that have to help hold the baby down so you can suction. Again, we have to like hold down a lot of babies and kids, but it's for their own good. That's what I tell myself. As someone who loves kids, like that part's kind of hard.
Yeah.
But I know it's for like their health and their own good. So
yeah,
I would say a lot. I don't know how to quantify that. We are always helping each other out. Yeah.
Nice. Wait, so you guys have like what, 10 nurses at a time on the floor? Or?
It can range depending on how many patients we have. So we'll just do it this way. Usually we have like between 25 to 50 patients. 25 when we're very slow. We're approaching winter, which on a respiratory unit for me that I'm on means we're going to have a lot of patients with respiratory infections. So we'll be maxed out at around 50. So I guess that's about 12-ish nurses, 12 to 13. At the most.
So like that seasonal thing, like why is it that people tend to get more infections in the winter?
That's a good question. I don't know exactly. If I were to guess, I would say it's colder weather. And that's just usually some of these infections are seasonal. Like it's flu season from about now to April. Get your flu shot if you haven't gotten one.
Get your flu shot.
That is my one plug.
I will get my flu shot. I was supposed to get it today.
Think about it though.
No, I was supposed to get it today, but
the flu is a virus, which means you can't really treat it once you get it.
Yeah.
Like we talked about prevention earlier. The only way to treat the flu is to prevent it with a flu shot.
Yeah.
So the only real treatment you have for the flu is the flu vaccine. So
yep. Get vaccines, people. Make sure you get vaccines.
I recommend it.
Yeah.
I don't know what I was saying because I was so passionate to get this message about
I think we were talking about why more infections in winter.
Oh, yeah, I don't know. I would say something about maybe it being colder. It's somehow affecting. I don't know. That's a great question. Yeah. Look it up.
I guess we'll figure that out.
Yeah.
Let you guys all know. But,
yeah.
Nice. Well, we've been talking about an hour. So, anything else you want to tell people? How can they stay healthy?
How can you stay healthy? I would say, it's just a daily lifestyle thing, a little bit at a time. Diet-wise, just try to cut out some things that are not healthy. You can still have them every now and then, but
like sugar.
Cutting down on your sugar and salt intake and increasing the amount of vegetables and fruit you're eating every day. It can be little changes, like maybe just add 1 serving of fruit a day. It's better than nothing.
So I think a lot of people know about the sugar one, but what is the normal amount of salt you should be taking a day? Do you know?
That's a really good question, and I don't know off the top of my head. This is really random. I want to say it's maybe 2,000 milligrams. Might be wrong. Don't go based on that. This is not legit health advice.
Yeah, I don't know. That's interesting.
I would probably the CDC's. No, probably.
Yeah, I think the CDC probably has something.
Might have some actual parameters for you, but
yeah,
just try to avoid a lot of added sodium.
Added sodium, okay.
I mean, if you look at wrappers, they'll tell you the amount of sodium, and if it's like 50% of this item is sodium, maybe not a good thing to eat all the time. Every once in a while, I guess, but I don't know.
Yeah.
Find things you like to do for activities.
Yeah.
Even just walking a little bit every day.
Yeah.
Can have a huge impact on your health. So if you like taking nice strolls by the park, I don't know.
Nice.
Yes.
Yeah. Well, thank you for your time. It's great talking to you, Amy. And hopefully people learn some things. Make sure you thank your nurses when you're in the hospital. How can nurses be appreciated more, I guess?
That's a good question. Honestly, saying thank you is means a lot to us. Because most nurses, like I said, are nurses because they actually want to help people. And sometimes it might be a really hard day and we might feel like we really didn't do a good job. And if a family member thanks us, we at least know, okay, maybe we made a small difference today. When family members have thanked me, it really means a lot. Literally my first day as a nurse, a family member took her time to thank me and even got a little gift, which don't feel like you need to buy your nurses gifts. We are not expecting that, and a lot of us feel awkward accepting things like that because we're just doing our jobs. But the point of that story to say is it was my first day and I feel like I wasn't doing that great, but her telling me that kind of just it made me feel okay, maybe I am making a difference here.
Yeah. I think you guys are.
I would hope so. Sometimes it doesn't feel like that.
I mean, healthcare would not work without nurses, so yeah.
Yeah, I guess maybe what you people don't realize is okay, so doctors are super important because they have to diagnose the patient and prescribe all the treatments. But think about everything they're prescribing. How does it get done? The nurse is the one giving all the meds that the doctor prescribes, doing all the procedures. For the most part, sometimes a physical therapist or something will do some things, or a respiratory therapist. But for the most part, anything that a doctor orders or that a patient needs during their stay in the hospital is done by a nurse. So they're kind of the behind the scenes people. And yeah, I don't know. I think there's some great people.
Yeah, great.
I have a lot of great nursing friends.
All right.
Just say thank you. That's all we need. We're simple.
Yep, make sure you guys say thank you. All right. Well, I'm also now going to thank you for taking the time to talk with me, come on this podcast.
Of course.
Yeah, hopefully we'll get some more stories soon.
Yeah.
We already had some pretty interesting ones, so.
Well, sometimes I restrain from going into the very fun ones that involve maybe a lot of vomit or poop, because I don't know how much people can handle those. So,
it's okay.
Maybe another time.
Anything goes in this show. But yeah, all right. Thank you.
Thanks for tuning into this podcast. Be sure to head over to iTunes, give us that 5-star rating. You can also find us on Spotify and Google Play. Talks with Toe is written and produced by Chris Toe. National Nurses Week happens every year from May 6th to May 12th in honor of Florence Nightingale, the founder of modern-day nursing. But that doesn't mean that you can't say thank you and show your appreciation to nurses. Our healthcare system wouldn't work without them, so make sure you guys do that. A simple thank you can go a long way on those 12 to 13-hour shifts. Music is by Purple Planet. You can visit their website at purple-planet.com.